And our last presentation is by Rebecca Block on AYA-specific programs.
Hi, thank you for this opportunity to speak today. I'm going to talk about an information gathering project that I completed that was originally requested as background information for the September State of the Science meeting that has been mentioned several times. I do have quite a lot of data, so some of the slides I'll go through kind of quickly and comment on only minimally, just so you can at least get a look at all of the information that we have. So originally we had identified 23 programs that self-identified as AYA programs that we were able to find. 20 of these programs were actually reachable, meaning they actually returned my email or phone call. Not to say that there are only 20 AYA programs in the country, but these were the ones that we could find. We decided to sort of take a survivor's approach or a patient approach. As a young adult, one would get on the computer and Google. And so that's what we did. We might have done a little bit more in-depth Google searching than a patient might have been willing to do, but that's how we identified the programs. We did a two-part information gathering. The first step was a phone interview, and the second was a survey that respondents were asked to complete on their own. Keep in mind that all of the questions in the interview and the survey are about implementation of the NCCN AYA guidelines and the critical elements that were identified in the Livestrong Young Adult Alliance paper that had been published, I believe, in 2010. And so these weren't general questions about what does your program do. These were very specific items listed in these elements and in these guidelines. Based on all of the data that we gathered, I was able to identify 8 different program components. And these were actually components made up of some elements from the NCCN guidelines and some elements from the 9 elements identified by the Young Adult Alliance. And today I'm only going to talk about the psychosocial component of the 8 components. I'll only talk about the psychosocial one. I'm also going to just mention the personnel. One of the items in the Livestrong Young Adult Alliance paper identified relevant personnel for AYA programs. And so I'm just going to show you the numbers on psychosocial relevant personnel, and then talk briefly about, in my opinion, the policy implications of the information that we learned. So here you can see, again, the list of personnel comes from the published JCO paper identifying different kinds of services or service providers. You can see they've been organized based on the fewest number of programs to the most number of programs. And those numbers down at the bottom are how many programs, how many AYA programs say that they have one of these people. So there were no AYA programs that said they had legal counsel. That's not to say that the patients do not have access to legal counsel, because all of the institutions, I believe, said that they did. But this is actually that the AYA program themselves has an attorney that patients can talk to. And then you'll see in the opposite extreme, the majority of programs do have peer support, and they do have partnerships with community-based organizations. To show you, again, this is a lot of information to sort of take in, but basically what this shows you is which pieces of the NCCN guidelines and which of the Young Adult Alliance elements actually come together to make this psychosocial component. So again, that component is a conglomerate of pieces of the guidelines and pieces of these elements that you can see here. I pulled comprehensive psychosocial assessment out as its own. You'll see some other tables that collapse information a little bit more. But I wanted to show this on its own because As a licensed clinical social worker and a psychosocial researcher, comprehensive psychosocial assessment is extremely important in my world. And so I feel like this is important to talk about on its own. You'll see that 15 programs report that patients who have an indicated need will receive a comprehensive psychosocial assessment. And we'll talk a little bit more about that later, but that's an important point, that it's not that 15 AYA programs are assessing their AYA patients all the time. It's only when a need is identified. As you can see in the table, there are 6 programs that say they implement an AYA-specific assessment, and on that second line, the NCCN has 24 different components that they suggest to include in a comprehensive assessment, and as you can see, all 6 of those programs are touching on over 12 of those 24. 9 of the programs have a general service for assessment. This means it's not necessarily AYA specific. It's just that patients in general get some sort of psychosocial assessment. And you can see 2 of those programs have 7 to 12 of the suggested components, while 7 of them have more than 12 of those components. Again, excuse me, a lot of information on this slide. Let me orient you a little bit to the information. You can see obviously the service is that first column on the left. Available means how many AYA programs said that their AYA patients have access to this, that this is available to them. That next column, institution and or partner, that means that the institution or a community-based partner or jointly the institution and a partner are providing or implementing that service. And then that final column, you can see what the AYA programs themselves are providing. So again, what we're looking at is what's AYA specific based on what is provided by the AYA program. So we're using provision by the AYA program somewhat as a proxy to inform us of AYA specificity. And again, they're ordered, so you can see at the top the most common services provided, and at the bottom you can see the least common being provided. Community partners, I thought that this was important to highlight. These are the services and how many programs rely solely on a community partner to provide this. So that means that the AYA program is not doing this, the institution is not doing this, but this is completely a referral to a community-based partner. This next one, the elements from the Livestrong Young Adult Alliance paper we collected as qualitative data. So this is somewhat of a categorization, if you will, of those qualitative data. The element that was listed is the assessment of and attention to psychosocial needs of AYA patients. And as you can see, how they're assessed, either it's ongoing needs assessment, some do formal assessments, some sites talked about neuropsychological testing based on diagnosis and need, others talked about the use of an intake questionnaire. Attention, again, you can see the variety, whether it's referral to the community or whether it's psychosocial support within the program. A little bit more about who's providing the psychosocial assessment and attention. You can see a variety of personnel, and then whether it's done compulsory or just as needed, and overwhelmingly it was based on an identified need. One of the questions we asked for every one of the elements, we asked how each program was measuring effectiveness, and you can see here that these are some of the ways that effectiveness was being measured. Some of you might notice that there are not any common outcomes here. This is a lot of counting things and satisfaction, which is great, but as I'll mention at the end of the talk, that's not where we need to be right now. Referral to age-appropriate resources. Again, this was another one of the elements. You can see who refers. A wide variety of personnel are referring, and referral resources there are a variety of materials that patients are being provided or directed to. And how is that being assessed? Again, how many patients are being reached? You'll see a quality improvement mentioned multiple times. I'm pretty sure this is the same site, the same AYA program who is engaged in quite a bit of quality improvement. Another one of these elements is assistance with sexual dysfunction and body image. Again, you can see the personnel. It's sort of the usual suspects coming up on the list, which it's nice to see the variety of providers working with patients in these areas. And then you also see the different referrals and program components meant to address sexual function and body image. Again, how are these being assessed? Mostly satisfaction and counting things. There is some evaluation, although we did not get any details in our survey about exactly what those details look like, or what those evaluations look like, excuse me. So I want to spend a few extra minutes here to talk about, I use the word conclusions loosely, but one of the largest learnings here, and this was probably not shocking to anyone, but AYA programs are structured very differently, and they're meeting patients' needs very differently. And I think this is very much exemplified when you see a list of 10 or 12 different personnel or healthcare professionals providing similar services, but at every site it's somebody different or a different few people who are providing these services. So there is an extraordinary amount of diversity. I almost felt like talking to 20 different programs, there were 20 different programs. And while there were some common elements and more common activities, as you saw on those earlier slides, there's still a great diversity in the actual delivery of those components or those services. Again, back to the assessment issue, because this was I feel like this is extremely important. Assessment primarily happens when a need is expressed or informally identified. So what does that mean? That means a patient says to their oncologist, I'm having a hard time. I'm worried about my treatment. I'm feeling anxious. My mother is driving me crazy. Whatever it is, but it's coming from a patient. It might also be coming from a healthcare provider. Several sites said that nurses and social workers were usually the ones who flagged patients. Most often it was nurses. It was nurses who would go to the oncologist or nurses who would make the referral to the social worker to say, this patient's having a hard time and we need the social worker to look into this and to do an assessment. But what is not happening is that those assessments aren't happening unless someone's noticing or unless someone's saying something. The other piece of this, similarly, is that in general, most of the programs, the areas that then are assessed are only the areas that were identified as problematic. So if a patient says, my mother's driving me crazy, the only piece that gets assessed is family communication and family support, as opposed to seeing that as a flag to say, okay, well, if your mom's driving you crazy, I wonder what else is going on. Or what is it that's happening for you that's allowing you to let her, make you feel crazy? And what's happening for her that is allowing her to do these things that make you crazy. So again, majority of programs are only assessing when there's a need and only in the area that those needs were identified. This is not all programs. There are some programs that there's one program who does a comprehensive assessment on every single AYA who they touch. I'd like to see us all get there. You'd also notice by the diversity that there's no standardization to the interventions or the assessments. So on the earlier slide where you could see that there are a lot of services being provided by many programs, what that actually looks like, the intervention identification in the NCCN guidelines is peer support. In-person peer support is how one of them is entitled. Pretty much everyone said yes. But what that looks like is extremely different. And you could see a little bit of that in the qualitative data. But A, we don't know what it looks like. B, they're probably looking really different based on what we do know. And C, and maybe most importantly, we have no idea what they're actually doing for people. Because again, what the majority of programs are collecting are how many people are being reached, how many referrals are being made into the programs, and whether patients are satisfied or feel good or are happy about the program. Not to say that any of that is unimportant. Of course that's important, but it's not the only thing that's important. Which brings me to my next point about outcome evaluation. This is extremely, extremely limited, as you saw from all of those assessment slides. I have to say that after completing this project, I felt that the biggest conclusion I had was a laundry list of additional questions. And most of those questions really center around what should AYA programs be offering? Because that's not what we were asking. We asked, what are you doing? Are you doing this? Are you doing this? Are you doing this? And what we don't know is what should be done, who should be doing it, and what are the priorities? Who gets to decide what should be done? I like to use the chaplaincy as an example because I think it's an easy example. One could argue that every hospital should have an AYA chaplain because the way you interact with an adolescent or a young adult who might be in a phase of sort of existential questioning and spiritual searching, that might be very, very different than how you would approach an older adult or a family with a young child who is more likely to be in a more kind of steady place with their existential understanding. At the same time, no AYA program has their own chaplain. And I have a feeling we'd all be hard pressed to say that every AYA program really needs to have their own chaplain. But we can argue, my point in using this example is that we could argue this with every element or every service. And now, again, that big question is, what really needs to be AYA specific? Who decides that? And then how do we implement it? So what does that mean for policy? In my opinion, my soapbox is we need consistent and appropriate psychosocial care, but it needs to be based on comprehensive assessment. So it's great to do what we think patients need. It'd be even better to do what we know each patient needs. Also, policies have to target availability of developmentally appropriate psychosocial care, but not necessarily dictate the pathway to care. And this really speaks to something that this project did not address, which is the difference between an AYA program and an academic medical institution and a community hospital who is capable and prepared to serve AYAs or actually have an AYA program. So it's the service, it's the care that we need, but the pathway of how that care gets delivered is likely to be, it needs to be delineated, but not dictated, because it needs to be varied based on setting. Evaluation of quality must be required for all psychosocial care, and that measuring satisfaction isn't enough. We actually need outcomes. What are these interventions actually doing? Are we actually changing the things we think we're changing? And are we measuring those on shared metrics? Because if I'm measuring something one way and Dr. Zebrack is measuring it completely differently, we're going to be hard pressed to be able to say something about the change that we're making. And finally, this has come up several times in this meeting, that psychosocial care has to be evidence-informed. And I use the term evidence-informed because evidence-based is a bit precarious in this young field. But what we can do is make sure we're doing evidence-informed work and that we're collecting the evidence on the work so that in the future we will have evidence-based interventions. I don't need my additional slides for reference. Thank you.